the eye issues can be very challenging. I think patients in general with atopic dermatitis have higher rates of ophthalmic complications. And we're paying attention to these much more now because when we use dupilumab, if a patient comes in with conjunctivitis, we're often left with this conundrum of, well, is it a side effect of the medication or is it just because they happen to have hay fever or keratoconjunctivitis conjunctivitis or other ophthalmic comorbidities? And it's not always easy to sort out. So I think certainly if we're not convinced, right, if we have a history of a patient who had baseline conjunctivitis, ophthalmic issues beforehand, perhaps they're getting worse on dupilumab, but in that scenario where I'm worried about there was some baseline pathology, I'll definitely refer to an ophthalmologist because they're probably going to need a longer term treatment, and it's probably not just related to dupilumab in that sense. Certainly with an acute onset flare of conjunctivitis, I think that's a scenario where if you're seeing them a day or two into that or a week into that, it may be a good idea to have ophthalmology see them, because you may just be picking up random infectious conjunctivitis that has nothing to do with dupilumab, and coincidentally that's just presented in a patient who happens to be on dupilumab. So I have sometimes patients who'll come in, they've been on treatment for 3-4 months, they've had conjunctivitis for 3-4 months, it seems to flare predictably with, let's say, their next, their injection, and the next day their conjunctivitis gets a little bit worse. The history is just too good for it. It's too long and too chronic for me to really worry about some viral or bacterial conjunctivitis in that way. As long as we're comfortable that this is not an infection and that we can safely use an anti-inflammatory agent, whether we get that sense because the patient's had a chronic issue that's very clearly tied to the medication, or because they've been cleared by ophthalmology beforehand, regardless, using things like ophthalmic steroids tends to be very reliably effective, as is if one can get access to ophthalmic formulation of tacrolimus as well. We know tacrolimus in the ointment form, but it can be compounded in an ophthalmic formulation, and now we have some data to suggest that that's an effective option as well, where there is access to that. Dupilumab right now is really our only FDA-approved systemic agent for atopic dermatitis. I mean, technically, systemic corticosteroids are approved because they have such a broad label for all inflammatory disease. The FDA would never grant that level of approval in this day and age. But dupilumab is really the most extensively studied systemic agent in all of atopic dermatitis right now. And there certainly are more agents coming, but for the next several years, it's really the one to beat and the only one that we have available for us to use right now as an approved option. And what I've seen clinically in terms of the therapeutic response has really been very consistent with what we've seen in the clinical trial data. Sometimes you look at clinical trial results and you're saying, well, I don't see that in the real world. That's not the case in my experience. Really, we do see results that match what we see in the clinical trials. And in the clinical trials, what we're seeing was, depending on the study design, about 80-85% of patients who are achieving that EASI 50 response, which I consider to be a very good response. And then you have about 40% of patients who would get that EASI 90 that I sort of consider as a super responder. And often those EASI 90 patients may not have to use much in the way of topical therapy. But really, across that, there's a therapeutic range. Not everyone's going to get that super response, but often, even when they still have a few lesions left over or they're still itching a little bit, they're still very, very happy because they're tolerating the medication well and they're getting a good therapeutic efficacy, certainly better results than any of the topical therapies ever gave them. I think there's always going to still be a role for some of the older-fashioned immunosuppressing agents. For patients who are uninsured, underinsured, or in the insurance company, we have limited access to the newer therapies. There's sometimes there are scenarios where we may not be fully confident in the diagnosis, where we're having a hard time distinguishing between a nebulous case of psoriasis or atopic dermatitis. And I think sometimes with the oral immunosuppressing agents, they're a little bit broader and perhaps more reliable in those cases. When choosing from the oral immunosuppressing agents, the one that has shown the most evidence in the literature is cyclosporin in terms of its efficacy, but we know that cyclosporin is not a great option long-term methotrexate and azathioprine have shown relatively comparable efficacy throughout the literature, although recent studies have suggested that methotrexate, when dosed appropriately, probably edges out over azathioprine in better efficacy. And in my experience, it's actually better tolerated than azathioprine, with less side effects that I have to worry about, and less laboratory, or maybe less expensive laboratory testing that I need to be, needs to be done.